Yay, there you go.
It's unbelievable.
I know, that's so bogus.
I'm
So
so I'm so
you
I'm
on
so
live
disgusted with
punishment
them,
for a
man.
while.
I'm so disgusted with Instagram. Man. I mean, it's partly my fault, I guess, for being hacked, but it's just like, boy, they do nothing to help you whatsoever.
Yeah. Well, it's okay. I know their customer service is really, really,
It's
really,
it's
really, really, really bad.
it's non-existent. They don't
It
even have
is.
customer service. It's like I don't know. I mean, I guess because they're not really selling nothing. I guess because you're not really. I guess you're not a customer, but
Oh, they
it's
have all
like
the service in the world when they want you to buy
when they
their
want you
ads
to.
and stuff.
I'm just like, Jesus Christ, man. I was like, cause I'm setting it up, and I'm just like, okay, I'm thinking everything gonna be cool, but it's like, nah, you're banned from doing lives, guy. I was like, oh, okay, thanks. I'm the hacker,
That's
so
crazy. Well, hopefully it's not a permanent thing,
we'll
because
see.
obviously it's more sense for it to be on your page later, but at
Yeah,
least we still able to do it for now.
yeah. At least it's here, so we figured it out. So I'm not gonna trip too much. So let's get into it.
All right. Well, welcome back, everybody. Sorry that we missed a month. If you've been following the DocP and Cola Red show, uh, I am one of his patients. I had surgery. I am at like 12 months post-op now.
Damn,
Um,
it's been that long. It's
yeah,
crazy.
September 1st was my surgery versary. So I'm
Impressive.
sure Sean is so mad at me because for the whole month I'm FREE fibroid free around the house. He gonna call pathology and be like, she need it back. She don't know how to act.
Shit, I bet you.
I've been clowning all
Nah,
week. I mean,
get that
all
back.
year, basically, or whatever. But
You
I
deserve it.
shared my journey on social media. I shared all my fears, all my vulnerability, all my questions, how I sought out my surgeon, everything. And then we've been actually doing visits every month to allow other people to ask health questions, maybe screening questions that they wanted to know more information, and also some things to open up conversations with your own physician or give you the right direction when you are in that office visit. So like I said, we missed a month, so my list is very long. But I
I
know,
bet. They been hitting
but
me with. I was like, look, just ask on the line because like somebody had asked me to like explain some stuff. I was like, listen, please, because I only want to say it one time. So just land, ask it
yeah,
during. If you don't ask during this time, then you're gonna have to wait till next month. So,
right.
but
So what I
we'll
would
get to
like
it.
to ask for everybody to do tonight, that if you are watching, I got a list of questions that people submitted already. If you are in the live, you will notice that there's a chat bubble at the bottom of your screen with a question mark. Instead of putting questions in where it just say comment, please put it in the question box, because when you put it in the question box, I can scroll back through it and I can screenshot it before we get off live, so I can make sure that if we don't get to it tonight, you are on the list, because we're going to, as long as people want this information, we're going to keep on doing it. Sounds good? All right.
Sounds
So
excellent.
to kick it off, do you want to talk about your hacking experience?
Real quick, I mean, because I want to say first and foremost, thank you for everybody that had common sense, right? I've been like I've made it because I did my first post ever like in 2014, like on Facebook, where I started educating people, and since that time, like granted, I'll do like some funny stuff here and there or some other stuff, but the overwhelming majority is geared to educate, and so if you ever see anything from me where when I'm asking for money or doing something that's just like just buffoonery or coon stuff, like it's not me. I'm just not that person like on social media. I'm not that person in real life. I'm just not that. So for everybody that looked to say, hey, this dude has been giving consistent content for like 8+ years, and then all of a sudden he got, vacation pictures with with Forex thing asking and then bragging about Lexuses, old Lexuses at that. Like, come on, people. Old
Oh, damn,
Lexuses,
busted.
old busted ass Lexuses when he has a Tesla and, you know, and bragging on Cash Apps. It's like, man, come on. But for everybody that had a brain that said, this ain't him, thank y'all. But y'all will not believe how many people was just like, oh, yeah, you're doing it. Or sent this dude money. They sent the money. I just refused to get extorted. I just wasn't doing it. Like, I just said, you know, I'm not going to do it. If they give it back to me, give it back. I'm not starting it over. I'm just not starting the page over. I got too much content. I've done too much. I'm not going to start all over. And then I got patients that are actually waiting on me to post stuff, you know, my new information from my clinic, which, by the way, I've signed a contract. I know exactly where the clinic is at. The clinic is up. It is near Mount Sinai Hospital. I am going to have everything for you guys within the next week or so, where I can post it and put it up. But they have to get the staff ready for all of the phone calls and all of the patients that I promised surgery and all that stuff. It's finally. I know I said August, September. I know I'm giving some dates. I've been trying. But it is, I promise you, it's here. I've signed the contract. My name is on the dotted line. It is there. I should be starting to take patients November 1st. That's still tentative. And I should be operating. This is the longest time that in my entire career where I haven't been operating. I have not operated since the last patient I posted, which was June 1st, 2nd. So it's been like 3 solid months where I have not operated. And I'm like dying. I'm like a fish out of water. It's as much as it's hurting y'all, it's hurting me. Like, I really want to operate. I really want to get to it. So please believe it's not me playing around. I just have to get my stuff together. But I got it together. It's coming. You will just see it. You will see all my stuff. I promise. I'm gonna just for an entire week. I'm just gonna keep posting and posting and posting the location, the phone number, and everything. So you guys will have that stuff. And I should be starting to operate back in November, starting early, real heavy December, real heavy January. So everybody that I promised surgery to, it's been waiting. Time is here. Just be a little bit more patient with me, and I promise I got you.
All right. Well, that was ESP because that was going to be the first question because that was number one. When is it coming? When is it coming? What did you heard about practice? Can I make an appointment yet? So that was actually number one.
Yeah, I tell you, I got it. I promise you, the contract is signed. I actually know the address to the hospital. I mean, the address to the clinic and the phone number. I have all of it, but I cannot release it because it's going to be unfair and not advantageous to the staff or to anybody. Everybody start calling there before stuff is set up. So we have to have a couple more meetings, get everything kind of situated. And then once the staff is ready, then all of the phone calls and stuff could come in, you know, to get things squared away. I mean, so people can start getting appointments. I can start scheduling surgeries, do all of that stuff. So it is coming.
All right. Awesome. All right. So let's move on. We're going to go into a couple of fertility questions to kick it off.
Okay.
All right. How long should you try naturally conceiving before fertility testing? Is it true that you need to try a whole year first?
So the definition of infertility is 12 consecutive months of no pregnancy with active attempts at pregnancy, right? So if you know, because there's a thing called a fecundability rate, right? Meaning the percentage that you can actually get pregnant per month, which is, believe it or not, it's only 20%, right? So meaning that it's like those odds are really like worse than Vegas. Like if you have sex just on just a one night random out of the month, anybody, I don't care who you are, there's only a 20% chance that you can get pregnant, right? So you have to imagine you can sit at a crap table and crap out 5-6 times in a row. That doesn't mean you can't get pregnant. That means you may just not be having sex at the right time, you know, which is the biggest thing. You just may not have to be having sex at the right time, right? So for you to really be considered have primary infertility means absolutely no pregnancy during that time. So that's where that recommendation comes from. Does that mean you have to wait that long before you seek fertility treatment? Not necessarily, because it also depends on age and time too, right? So maybe you didn't You just decided at 40 years old, I've never tried to get pregnant. I've been on birth control. I've tried for 5, 6 months. It didn't happen. You don't have really a lot of time to play with. It's not to say that you can't go seek fertility treatment. It's just by definition, you're not considered infertile, which means that insurances, if they are going to pay for fertility treatment, probably not going to pay for it because they want to have documentation that you are actually infertile before undergoing fertility treatments. So it's just food for thought. It's just definitions, just understanding. If you really, really, really want to know if you are, have the ability for pregnancy, it's a couple of different things that you need to do. Number one, first and foremost, get a semen analysis, right? Because 50% of the time, infertility is due from male factor. We always think, as general, like we always think that infertility is because of the female. That is false, right? 50% of the time, it's the male, whether it's low sperm count, whether it's varicocele, whether it's multiple different issues that the man is actually having where he has poor semen quality, which is preventing pregnancy. So you need to know that. You don't just automatically assume that it's the woman. Number two, you want to make sure that you're having sex at the right time, right? So an ovulation predictor kit, which is easy. You could buy it off Amazon. You could buy it from Walmart. It's just basically giving you an indication when you're ovulating. If you're not having sex during ovulation, then that means you're not going to get pregnant. That's really only a 4 or 5 day window every month that a woman can get pregnant. If you're having sex like during your period, right before your period, or even right after your period, you typically are not ovulating and you're just practicing. All right. So understanding when to have sex and having sex at the right time is also important. So doing those things can actually eliminate eliminate some of the quote unquote infertility issues just by doing those two particular things. And then if those things aren't working, never been pregnant, your partner's never had anybody pregnant, rule all of those things out, then you can go seek fertility treatment because it's expensive. Obviously, if you could troubleshoot it without having to go to the doctor really early, then troubleshoot it. You don't have to go to the doctor. Sometimes it could be just as easy as an ovulation predictor kit.
All right, so that was the next question on the list, and you kind of said it already, but just so everybody hears, the next question was, I've heard different times of when you can actually get pregnant each month. Can you clarify how many days each month conception can actually occur?
Right. So in a normal, so just real quick, normally, if a woman has a 28-day cycle, and you can give or take a few days, she's going to ovulate on day 14. That's day 14 after your period starts. So, if you have a 4 or 5 day period and you look at the month in totality, let's say for instance, you have, your period starts on the 1st of the month, it ends on the 5th of the month. At day 14, between 13 to 15 is typically when you ovulate, right? So the egg is viable for, the egg can be viable for 48 hours, right? So you can have sperm that's in the system like 2 to 3 days after that. Before that, or 2 to 3 days after that, right? So that means if you have the sperm in the body for 48 to 72 hours, let's say you have sex on day 11 or 12, and the sperm is still viable meaning it's still alive to day 13, 14. When you actually ovulate, you can get pregnant then and be okay. And it also is going the same way. If you ovulate on day 14, egg is still viable for 48 hours, let's say 15, 16, and then you have sex on day 16, right? The egg's still viable. You have sperm that could be there. Then you can get pregnant after that too. So all through that time, that 4 or 5 day window, you can get pregnant as long as you have viable sperm, viable egg. Now, again, these numbers I'm giving you can vary a little bit, right? He said 2 days. No, this is how normally it happens. Maybe it might be 3 days, maybe it might be a day, right? So this is a range, right? Everything we're given is a range. So the range is about 5 days typically, maybe give or take a day or two. around there in which you can get pregnant. Once there's no viable egg anymore, and you just have just sperm, it's a freebie. It's practice, right? Sperm has nothing to fertilize, and you can just have sex and don't get pregnant. But you just have to really know when ovulation happens.
No, that makes perfect sense. So if you're just joining and you want to ask a question tonight, please feel free to ask one of two ways. So there's a question box at the bottom of the screen with a question mark in it. Please use that one. If you want to comment in the live, you can use the other one. But if you have a question, please put it in the question box. If you want to request to join the live, you can send a request and ask to be part of the live as well. And you can ask your question yourself. So I just want to say that because I see the numbers changing. So I know people are just joining.
Yeah, so you got total control over that.
Yeah, you might have to help me with
I'm in jail, so it's at the bottom. Like, so
okay.
when you'll see like the request, because I don't have my things, but it's
Yeah,
at those little things
I
at the
can see
bottom.
when people wave and do certain stuff. So
Yeah,
I'll be looking for if
but
somebody
they'll send a request if they want to pop on. I actually had one of my patients who's in med school now that wanted to hop on. I told her to hop on, so kind of be looking out for her if she's on watching.
Okay.
She has a pretty interesting story as well too.
All right, awesome. All right, so a question in the chat box. Can you tell me at what point should a woman with a prolapse of uterus, anus, and bladders consider surgery? Mine is a grade 2 to 3 for all three.
Great question. And for everybody that just kind of understand asking about vaginal prolapse or pelvic organ prolapse. And pelvic organ prolapse is when so your pelvis is structurally connected to hold everything in your belly up. So your bowel, your bladder, your rectum are all held up because remember, if gravity just pulled everything down and everything would just fall through the vagina, it's an open space, right? So you have actually tissues and muscles that are keeping everything structurally together. Well, with age, with genetics, with childbirth, with smoking, with chronic lifting, there are multiple different factors that factor into someone with pelvic organ prolapse. People think that it's always just pregnancy. That's not true. I have patients that have had one baby and are older that have significant prolapse. I have patients that have had 8, 9, 10 babies that have the most intact pelvic floor there is, absolutely no prolapse. So that shows you it's not just how many babies you have. It's age, it's genetics, it's what you do with your life. Are you a postal worker where you're lifting up big heavy packages every single day over an extensive period of time? Are you a weightlifter that has been lifting weights for an extensive period of time, holding your breath, while solving down, putting pressure on the pelvic floor, making it weak? So it's multiple different things that can happen. As far as how it can happen, as far as when it's treated, it's not something that will kill you, right? It's not something that's going to hurt. That's how we look at it, right? It's the same way with fibroids. Like fibroids typically won't kill you. That's why 80% of Black women have them. Everybody doesn't have to have surgery just because you have fibroids, you need surgery. The question is how the pelvic organ prolapse or how the vaginal prolapse is impacting your quality of life. If you are functioning perfectly fine, right? Meaning that your day-to-day activity is fine, like you're not missing any steps, you're not in any pain, you're not having any problems with sex with your spouse, like you're not having any issues, but you do see that or feel that there's a little bit of prolapse or push from the vagina, you don't necessarily have to do anything about that. That's with a caveat, because typically it can worsen over time, right? So if it's very bad prolapse and you're not experiencing any symptoms, there's an option to either treat it or watch and wait. Some women, that's why we have options. That's why surgical options are important, because everybody doesn't want surgery. Everybody doesn't want to have to deal with it. Some people are perfectly fine just taking a chance and see if it gets worse or if it starts to impact quality of life. You have options. So I can have somebody with a grade 3 prolapse that says, I am fine. I'm not having an issue. I'm not having to push nothing back in. I'm not having any problems with urination. Me and my husband have sex perfectly fine. I don't want surgery. Fine, mama. No problem. You don't have to. And you can also have the same one with the exact same thing that says, I just don't like it. It's uncomfortable with my husband. I'm self-conscious about it. When I'm out playing with my kids, grandkids, I'm having to push tissue back in. It is bothering me. It's an issue for that woman. Surgical options or a pessary will be the answer. So everybody is different. To say all of that, everybody is different. There's not a one way of looking at it to where it's a prolapse, gotta have surgery, right? Because it's not a grade 1 surgery or grade 2 surgery or grade 3 surgery. There's nothing in our literature or anything that says you have to, because it's still elective at the end of the day. Where it's not killing you is something that you want to do for a quality of life purpose, unless, right, if you have something called like complete procedentia, which is a term that means it's all falling out, right? So everything that's in there is poop out in the vagina, right? Meaning your uterus, vagina, it's all coming out, right? So that for that problem, yes, those women do need surgery, because it is like, it's going to be a pain issue. It's going to be a functioning issue. It's just not something that you could do. And I've had that. I do see that where, I've had patients, I think I posted that before, where I've had to perform surgery on a patient. They probably flagged it for community guidelines, and that's a whole nother issue. But anyway, if you have, it's crazy. Like,
they just want to mess with you, boy.
It's side topic. It's like, for real, like, you could post some of the most crazy stuff, crazy shit on freaking Instagram. Like, I'm scrolling, I'm seeing Gawk 3000s, straight head devices, right? You could do this stuff all down to Amber Rose. That's her whole platform, is talking about head and Gawk 3000s now. And you could see this shit all damn day. I post something about, like, legit on TikTok. I posted about the difference between laparoscopic and laparotomy, right? No patients, no nothing, just showing what happens, and they straight flagged it for community guidelines. I'm like, it's fucking education. Like, what do you want? What are you talking about? Like, if you are so immature that you can't, like, look at pictures of, like, fictitious pictures down there, that's flagging community. I'm confused. Somebody could help me with it. I'm getting so frustrated with this whole thing. It's just like,
you might have a hater that's flagged it for you.
Yeah, I think they do it. That's when they come, the administration for these damn things come. You want to worry about, like, actual things that are helping people versus, and that's just, I'll get on my soapbox. Let me stop, because it's just like, the stuff that we care about in a society of what we want to see and what we're okay with versus stuff that actually helps. It's whack as hell. But nonetheless, that's my answer to the pelvic floor issue. I hope that clears it up, because I think I know the person that asked that. She sent me a DM, and I told her to ask that on the live, because I wanted everybody to hear it. That's how prolapse. And now, and always, if you do have prolapse, surgery is not always an option. I mean, surgery is not always necessary, where you do have options. Like, some women just don't want surgery, but there's things like a pessary, in which it's a space occupying device that you place in the vagina that basically is like a temporary tent that pops everything up. You can do that all day long, but you can't have sex with it, so it's cumbersome. You got to put it in, put it out if you're still trying to have sex, or it's just cumbersome to deal with. But it's a way to treat the problem without performing surgery. It's an option for women, so there are other options available. You just have to really talk to your physician, and they really have to understand how to treat pelvic floor disorders.
All right, thank you. So again, if you're just joining, you can still send a request to join in person to ask your question. I'm watching it, and I think I know which button to press. So definitely, if you want to join, feel free. All right, next question in the bubble. I am currently taking Urethra norethindrome.
Norethindrome. Yep.
Okay. But I am having really bad cramps. Should I stop taking it?
The question would be, what are you taking it for? If you're just taking norethindrome for bleeding, or you're taking it because you're on some other hormonal suppressive like a Lupron, and you're taking it for AdBac, it's multiple different reasons why you take norethindrone acetate, but that may not be the reason why you're having cramping. If you're taking it to counteract the cramping, then you need to figure out, one, what's exactly causing you to have cramping, and having a better treatment to treat your bleeding. Because typically, you're taking norethindrone either for bleeding or for AdBac, for other medications.
And they said that they are taking it for, they just popped in. They're taking it for excessive bleeding.
Right. So there are other things that you can take for bleeding. It's the bleeding from fibroids. It's the bleeding from abnormal bleeding from a polyp or a structural cause, or medications, or whatever. You can have abnormal bleeding from a multitude of different things. So diagnosing, one, why you're having the bleeding is the first thing. But the common mistake that I see a lot is providers really don't understand bleeding, which is crazy. But it's true. We all not built the same. You got good lawyers, you got not so good lawyers. You got good doctors, you got not so good doctors. You got good hairstylists, you got not so good hairstylists, right? So, you got to do your research behind who you're going to and trust them with your health. Right? Like I tell you guys all the time, do your research and understand that they should be breaking things down. They should be giving you a full comprehensive evaluation to diagnose where your bleeding is coming from. I still know providers that like, oh, you coming in with bleeding? Nah, I just throw some birth control at it. That's not how you do this. So if they're just putting you on norethindrone acetate and they're not diagnosing why, or they're not discussing, like, if that's not working, what else needs to be done, getting ultrasounds, doing exams, figuring out what the true problem is, then you should have questions. So I wouldn't just necessarily just say stop it. It should not be hurting you. It should not be causing the cramping, but it may not be the fix for the cramping. So with that being said, it's up to your provider, between you and your provider, to figure out why you're having the cramping still, and to figure out what the treatment option is best for you.
All right. So we got somebody that's willing to join. So I think I did it right. Oh,
we're gonna see.
It declined. She declined it.
Oh, she declined shit. Yeah, that happens.
Okay. All right. So, but at least I know how to press it. All right. So if you didn't mean to decline it, send it back. I will get you. We'll go to the next one, and I'll keep watching that box. All right. I was previously diagnosed with PCOS, but lost 75 pounds last year. So now my periods are very regular and precise. I am 40 years old, but I want to know, if my periods are very regular and precise, does that mean I have a better chance at getting pregnant?
First of all, congratulations to you, because that's one of the treatment options. So PCOS is polycystic ovarian syndrome. Just a little bit of background. Polycystic ovarian syndrome, the one wrong thought of it is that it's always because of obesity. That's not true. I have patients that are thin, that are skinny, that have PCOS. So it's not just a disease state for large women. Hello.
Yeah, you could keep answering. I just wanted to accept it before it expired. So we got problem. You up next. Okay.
All right. So it's not just a disorder or disease for women that are larger. However, a overwhelming majority of women with PCOS are larger. All right, and that's part of the disease state, right? It is a disease of unopposed estrogen, meaning that there's too much estrogen in the system, and that can be caused by one, insulin resistance, where you have a high level of insulin that's throwing everything off, but also two, when you have fat, like excess fat, you have excess estrogen, because estrogen is created in fat cells, right? So that's why one of the treatment options for PCOS, if you are obese, is to lose weight, because you decrease the amount of adipose tissue and thus decrease the amount of unopposed estrogen. So for your case, if you have lost weight and now you're in a normal cycle state or what have you, that's awesome. You know, it could be to the point of now you could come off of any medications that you were on just to see if things regulate. And then, you know, if pregnancy was your goal, then, you know, you could try to start seeing if, you know, you have ovulating appropriately and doing the steps, the preliminary steps that you need to do for pregnancy. What was her question in particular, in specifics
She
about
just
PCOS?
said because they're regular, does that give her a better chance?
Absolutely, it gives you a better chance. So with any woman, doesn't matter. If you are having regular periods, right, which there's a cycle, whether it's between a 21 to 35 day cycle, right, and they are regular clockwork, whenever that period of time is, your chances of ovulation are much, much higher. It's typically that you are ovulating when that happens, because periods are that's how it works. Your body has periods to have cycles to get ready to ovulate, get ready for pregnancy, things break down, recycle, repeat, right? So if you are having regular cycles, then that most likely you are ovulating. So obviously your chances of pregnancy are much, much higher. Also, too, for women in of themselves, obesity is a hindrance to pregnancy, right? If you go to any fertility specialist, a true fertility specialist that's really good, they don't really accept you if you are morbidly obese, right? Because they get paid off of their success rates, right? And they don't just, and the good ones do. And they're not going to just offer IVF for everybody, because if you decrease your success rates, then you impact your money, unless you just want to take everybody's money. But if they're telling you appropriately, they want that BMI to get as close to 30 or under 30 as possible, which also increases your risk, increases your chances of pregnancy. So you are doing the right thing, mama. I'm proud of you. That's awesome. Keep up healthy lifestyle, exercise, diet, you know, keep your BMI as low as possible. You know, and then you are doing everything that you can do to optimize your pregnancy. And from there, that point on, you know, if it doesn't happen, then you could seek fertility specialists. But, you know, go ahead and try it. Your chances are good.
All right. Okay. So welcome to the live. Thank you for joining.
Yes. I accidentally clicked it because I didn't realize that, but no, I'm so glad. This is probably like, this has to be God, because my friend actually sent me your IG page, because she worked with you. She was a labor and delivery nurse, a travel nurse, and she worked with you when you worked at the university, I think it's Chicago, one of the hospitals in Chicago. And she kind of worked for you. So she said, hey, you should try to reach out and get a consultation with him, because I've dealt with fibroids for quite some time now. And so I had an open myomectomy in 2018. The fertility, he did a great job. My incision was very small. Awesome. Like, you know, it's barely even there now. Did a wonderful job with the incision. So my husband and I, we were trying, but didn't really try probably like as we should have. And so the fibroids have grown back. And so right now, and this is crazy because I literally pushed back a consultation with a new OB I have, because I was going to be reaching out to get your next opinion before I make whatever decision I'm going to make pertaining to these current fibroids. So I went back to the same fertility doctor who did my myomectomy in 2018 this year. And he's like, yeah, you know, I have a submucosal fibroid, that's, I think it was measuring about 4.5 centimeters. And I have another one, I think it's an intramural. I don't know all the terms, but I
No,
know
it's
the
no, you're
submucosal.
right. No,
Okay,
that's in. Go ahead.
an
You're saying the right thing.
intramural
Go ahead.
one, that's about 3 centimeters, and
Not
then
large. Okay.
maybe one more that they think is outside the uterus. So
Okay.
he's like, you're not gonna get pregnant with that intramural fibroid, like, or that submucosal. He's like,
This,
it's just going to be really hard. You can do all the research. And he's an older guy. And so, I'm like, okay, well, I'll try to, I just need to figure out what I'm going to do and make a decision. So
mm-hmm.
I kind of was looking at your page and I saw that you do the I think it's Assessa.
Mm-hmm.
Okay.
Excessive.
And so I also saw the Sonata treatment. So I live in Ohio, and so there's 2 doctors in the Cincinnati area that do this particular treatment, Sonata, and I think it's similar to the one you do with Assessa, and that's what I'm still trying to get some clarification on.
Awesome. Okay.
And so I reached out to this new OB in Cincinnati, and I read great reviews. He came in, hit the ground running. He did a sonogram. He did a hysteroscopy very quickly. Like, I hadn't even had that procedure completed with the OB. With the fertility doctor before. So I feel like he's really trying to just pinpoint how many there are. And that's when he told me that there are 3. So I was able to clearly see that submucosal fibroid, 2 weeks ago. So I pushed back in my consultation with him just to figure out to proceed with I initially went to him for the Sonata. But my question is, I'm not so sure on it because there's not a lot of research on it with, preserving fertility after. And so, my question to you that I was going to have is, what is your experience been with women after Assessa who are still trying to get pregnant, or the Sonata treatment? And maybe explain a little bit more of those for women who are watching, because right now I'm over the heavy bleeding. It's I'm just kind of over it, and I know I need to get that particular one removed, or get rid of it somehow. But I'm trying to go as least invasive as possible. But right at this point, I just want to do it in a more strategic way. And so that was going to be my question I was going to ask you. And so this is amazing that I jumped on Instagram and saw that you all are on live because, like I said, this literally has to be God. So
gotcha.
If you could just kind of give some insight on that.
I got you. I've got a whole Rolodex. You first and foremost, I want to say thank you for hopping on because like you hit a ton of different points and I'm about to break down all of them.
Okay.
And thank you for being brave enough to share your story. It helps people. Like,
yeah.
Believe it or not, it's like having a whole classroom full of kids in your high school. They didn't want to raise their hand.
Yeah.
But they in there is like, I got a question. So like they come to this stuff and they listen to it and actually get it, but they just don't want to ask me or ask questions.
Yeah.
So like you just hit a bunch of different things. Okay.
Yeah.
Number one, first and foremost, just a little bit, just fibroids. And I'm gonna kind of, when I talk, I'm talking to you, but I'm also talking to people that really don't know. So you said a bunch of different things that I understand that some people may not understand. All right. So we always talk about location of fibroids. Like, remember, if I tell you guys anything else, fibroids are important for 2 reasons: size and location, right? So she had a myomectomy in 2018. Like I tell you all the time, I tell any patient, I don't care how great you are, as long as you have a uterus, there is the ability for fibroids to return, right? I tell patients that all the time. It can happen. With that being said, she had a couple of different fibroids. All of them are not large. 4.5 centimeters from what I'm listening to you is your largest one. 4.5 centimeters is roughly about like that. That's about 4.5 centimeters, right?
Yeah.
So we're not talking about a size issue. We're talking about location. Location is huge, especially in your case. So with the location, and I don't even have my little board, but location is important because imagine the uterus, all right? The inside lining of the uterus is the endometrium, right? So that's where you have your period from. The sloughing off of that lining comes every month. That's where your periods happen. Fibroids that push into the cavity of the uterus are where the babies implant, right? So if you have a fibroid that's pushing into the cavity of the uterus, the term that you use is called submucosal. That's what that means. That means the submucosal fibroid is the fibroid that's pushing into the cavity of the uterus. That decreases the chances of pregnancy, right? And they also increase the risk of pregnancy complications. So for a patient that is trying, can you get pregnant with a submucosal fibroid? The answer to that question is yes. And it's nothing is definite in medicine. Things can happen that we can't explain, right? You can have a patient with a submucosal fibroid get pregnant, have a full term pregnancy. You can also have a patient with a submucosal fibroid, depending on the size, they can't get pregnant, is having major issues, or has gotten pregnant, having early miscarriages from that submucosal fibroid. You can have two things that are true at the same time, right? But what we do know is that patients with across the board with submucosal fibroids, one, have a decreased chance of pregnancy, and two, if they do get pregnant, they have an increased risk of spontaneous abortion or not being able to carry the pregnancy to fruition, right? So she has a 4.5 centimeter fibroid. There's submucosal, meaning that part of it is pushing into it's unlikely that the entire thing is pushing in, right?
The measurement,
So
you said it was like 1.1 centimeter.
It's pushing in, right? So usually part of it is pushing into the endometrium, right? So with that being said, it also depends on time, right? So if you are 25 years old and you have a submucosal fibroid and you're not having pain, not having bleeding, not having any other issues, then you have time to see if it's going to be a problem. If you are 40, 41 years old and you are at the end of the road for trying to get pregnant and you have this issue, have had surgeries in the past, and now you're like, I need to get pregnant now, you don't have that time to play with. It is something that you need to address.
Right.
So with that being said, you said two different treatment options, right? One of the treatment options is Sonata. The other one is Excessa. Well, actually, you said three. You had Sonata, Excessa, and you also have had a myomectomy in the past, right? I'm going to break down all three of them. So Sonata and Excessa, they are in the same family. Excessa is a little bit older, right? So I got introduced to Excessa in 2013, right? Which is why I'm a super user. I've been doing it a long time. I understand it completely, which is why I back it. They pay me to go all around the country. Whenever you guys see me post stuff, where I'm in a different city, I'm teaching Excessa. Like that's what I'm one of the things I specialize in. Sonata, so Excessa is a laparoscopic radio frequency ablation of fibroids. What does that mean? It means very small incisions, putting a camera in the belly with small incisions, putting an ultrasound in the belly, and then using that piece to go directly to the fibroid, putting an ultrasound, and then putting a piece that goes in, sees the exact size of the fibroid, and then burning the fibroid inside the belly, right? That's what Excessa is. Sonata is kind of the same thing in reverse, whereas instead of you going through the belly, you're going through the vagina. And within the vagina, you're actually taking an ultrasound through the vagina. You're looking at the uterus, finding the fibroids, and taking another piece that does radio frequency ablation and doing the same thing that you're doing from the top down at the bottom. Right? For me personally, right, and this is just me personally, I'll tell you what the couple of issues they have with Sonata, right? One with Sonata is that their biggest issue is what Excessa had previous, right? Excessa really didn't become widely accepted and okay until they were able to get a code, like a procedure code that the insurances recognize and they would actually pay for. Right. So now, if you go and want Excessa, then I could say, I'm doing a laparoscopic radio frequency ablation of the fibroid, send that to the insurance company. They approve it. There's a code. It verifies. Hospital get paid. Surgeon get paid. Everybody's happy. Like everything's cool. Right. Sonata does not have that code. So a lot of hospitals are restricted of it because nobody's getting paid from it. And then two, that means that a lot of surgeons, it's a less used procedure because, it's just not widely used. It's not to say that it doesn't work. It just is not as widely used. Two, one of my issues with Sonata is that you can get to the fibroids. So the submucosal fibroids, those are safer, meaning that you can see them. You're coming in from the vagina, and they are protected because they are within the muscle of the uterus, right? So you can get to it and you can burn right there and burn the fibroid. The problem is that when you're going through the vagina, the uterus, on the other side of the uterus is everything else on the inside of your belly. Your bowel, your bladder, your fallopian tubes, your ovaries, your everything else that's in your belly that makes you live and function as a human being is on the other side of that uterus. So it's not a very comfortable procedure when you have fibroids that are more further away from that and are closer to the belly, right? That's where it gets a little hairy. So I think Sonata has its use for submucosal fibroids. When we talk about fibroids that are close, because you do have a fibroid that's also intramural, and you also have one that's called subserosal, which means that it's closer to the surface of the shell of the uterus. And when you have that, that means that it's a little bit more dicey, like depending on like how comfortable you are as a surgeon. If you're going to get those, you get the myometrial ones. I mean, the myometrial, or the submucosal ones, excuse me, and the myometrial ones. But the closer you get to that outer layer, like that's where it's the gray zone and the skill level and who you dealing with or whatever. Yeah, you got to be really, really careful with that. The other thing is too is that even when I perform excessive, if I have a I do excessive for multitudes of different reasons. There are patients with infertility that want a minimally invasive option to treat their fibroids with excessive. But if they have a submucosal component, then I will do what's called a hysteroscopic biomectomy first, meaning that 1.1 centimeter piece of tissue that you see there, I'm going to go in with a tool and I'm going to scrape that part out. I don't want anything pushing into the cavity. I want to address that part first. And then I'll go on top with excessive and burn the rest of it that's in the muscle. And my argument will probably be the same for Sonata. So if you're looking into Sonata and that's what you want, that for that submucosal fibroid that you request a hysteroscopic myomectomy, and that portion that's pushing into the cavity to remove that portion and then treat the part that's still there right outside of the cavity too. So that's what I would recommend. That's what, if you came to me and you said I want excess or whatever, that's what I would schedule you for. I would schedule you for a hysteroscopic myomectomy, meaning I'm going to go in with I'm going in with a camera, and I'm going to look at the cavity of your uterus, evaluate it, and then I'm going to take a tool that's going to what's called morcellate or remove the part that's actually pushing it into the cavity. And then I'm going to go to the top of your belly and I'm going to do the excessive procedure, put the scopes in your belly, and then I'm going to find that same fibroid, all your fibroids, and then I'm going to treat them from the top. That's what I would do. As far as a myomectomy is concerned, if you need a repeat or what have you, I don't necessarily think you necessarily do if you're not having significant pain or bleeding from your fibroids now. You don't necessarily have to have a myomectomy. However, it also has been proven that, if you have no fibroids there, yes, your chances of fertility do increase. So it just really kind of depends. I would have to look more at your particular case, look more at the ultrasound, look more to advise you specifically. But those are, your options in a nutshell. And when you're choosing between Sonata and Excessa, that's really what you want to kind of look at. You want to kind of see one skill of your surgeon. They need to break all of this stuff down for you, just like I am. And then, you start choosing the best option for you. As far as Sonata versus Excessa, I'm an Excessa guy. I mean, that's what I use or what have you. I've been trained on Sonata. I get it. I know how to do it. Similar concepts. I will say that the technology is different. Like they will have to step up the technology for where Excessa is at. Like you can get to things specifically better with Excessa. Right. That I feel that. Like, but with submucosal fibroids, it's pretty, it's pretty straightforward and direct with it. I don't think you will go wrong if you have a skilled surgeon that knows what they're doing to do that for you. But yeah, that's in a nutshell everything. I hope that answers your question.
Yeah, that definitely did. I appreciate that. So
No problem.
just have to think about some things a little
Yeah,
bit
you
more.
gotta think about it. I put
Yes.
something on your plate, but
Yeah.
that's giving you just information
Hmm.
specifically on them and what's happening. But like I said, I would love to just tell you all this, but I'd have to literally kind of look at everything, where you're at, look at your history and all that stuff to figure out exactly what makes the most sense for you.
Okay.
Okay.
Well, thank you. Thank you for your
You're
time.
welcome.
Thank you all
You're
for having
welcome. No
us.
problem.
Thank you so
Okay.
much
No
for
problem.
joining. All
Okay.
right. I think I can
See you later.
Just hang up. Okay.
Yeah,
Yeah,
that's what I was gonna
she gonna figure it out. The techno over there is she working it out. She got it.
Okay.
So just go to go to the
Okay.
go to the top part. Yeah, that part. Yeah. So the top part, you put that pull down menu at the top, color like that,
I get it.
and
Okay.
then
I get
there
it.
you go.
Okay.
So that's it. So if you are brave enough to come on here, you get free healthcare. Look at that.
Yeah.
She got a whole consultation free just by hopping on here and talking about it. So there you go.
Awesome.
You're welcome.
All right.
Thank you. No problem.
Next. Sorry. Okay. I am scheduled for a laparoscopic myomectomy and mini laparotomy to remove fibroids. Can you give your thoughts on that procedure?
I'm going to explain this. I'm going to explain this again. I'm going to keep talking about it. So the question was laparoscopic myomectomy with a mini lap. And my answer to that now is I do not agree. And I'm going to tell you why. I am a laparoscopic surgeon. I am laparoscopically trained. I am a laparoscopic guru. I could do anything through scopes, i.e. remove 6-pound masses for people's bodies, right? I'm all about laparoscopic surgery, except when it comes from myomectomies. And this is why, because I've done throughout my career, the first half of my career, I did extensive laparoscopic myomectomies. I did a lot of them. And what I've noticed from when I do open myomectomies is the recurrence rate, right? When I do laparoscopic myomectomies, the recurrence of myomectomies, or when they come back being a problem, is much higher. Why is that? Because when I do a laparoscopic myomectomy, I lose my ability to palpate. I cannot feel the uterus, right? When you do a laparoscopic surgery, you're basically putting trocars in or instruments into the belly, followed by and a camera, and that is allowing me to get the fibroids out with these instruments, and it's all that I can see. If I can't see it, I can't get it. With fibroids, people get kind of inundated with, I only have 3, I only have 4. It's all a lie to me, right? Because for every patient that says, for every time I've read an ultrasound that says they have 3 or 4 fibroids, I've been in and it's been 10, 11, 15, 20, 30. It's always more than what they say. The radiologist is only going to say the ones that are the biggest and the ones they feel like making mention of. They're not, if you got 20 fibroids, they're not going to list 20 fibroids ever, right? And a lot of the time, there are many more fibroids that are actually listed. So you have to imagine fibroids could be the size of a pea, right? Size of a booger. They can be that small. And if you leave something that small into the uterus, the chances of it growing into something that looks like this is it can happen all the time. And that's where I think the failure for laparoscopic myomectomies come from. It's not that it's not that it's a good surgery. It's the fact that if you leave disease behind, that it can grow. So getting all of the disease out is the most effective way to prevent it from coming back. That's problem number 1. Problem number 2 is that if you think about it just intuitively, and this is what I did, I just thought about it. I'm like, why in the world am I going to struggle? Because laparoscopic surgery is harder than open surgery, right? It's very hard to do things without touching it with your hands, to control things. It's like literally like almost playing a video game or really controlling robots. Like you're controlling things, not with your hands, but you're controlling instruments. So it's more difficult. It's more time of surgery. It's technically more difficult. It's better for the patient, right? You leave the hospital quicker, less risk of infection, less bleeding. Those things are all true. But when you have a myomectomy, meaning that I cut a fibroid out of the uterus and then I repair that uterus, the recommendation for those patients is to have a C-section with their delivery, right? So can you have a myomectomy and not? Yes, it looks into how far, how deep the fibroid is. Some patients can still have vaginal deliveries after it. But if anybody, any surgeon that sees that you've had a myomectomy before and you come to them and said, I've had a myomectomy, I'm pregnant, I want to deliver vaginally, their answer to you is going to be no. And because the risk of what's called uterine rupture during that time is very high, right? It could be as high as 3 to 4%. Nobody's going to take that risk. So if you've had a myomectomy, unless it was the actual surgeon that did the surgery and said, oh, there was no submucosal involvement, didn't push into the cavity. If you go to a new doctor, and even if you go to the same doctor, 99 times out of 100, you are going to have a C-section with that delivery. So it doesn't make much sense to do a laparoscopic surgery with small incisions, having a more difficult surgery and possibly leaving small fibroid tissue left in the uterus, only to come around and have a C-section, right? It makes much more sense to make a small incision as small as possible. And y'all see me take out really huge, large masses out of these small incisions. Those same incisions can be utilized for C-sections in the future. I would rather do that so that I could fill the uterus, take all of the fibroid tissue out, make sure I got every single fibroid, return it back, and then also use that exact same incision for C-sections in the future. So I hear this all the time. People want to argue with me about like, oh, you should just do laparoscopic. You don't know, you're trying to cut open women. If anybody knows me, no, I'm not. I'm all about minimally invasive. I'm all about recovery. I'm all about trying to give patients options. But when you talk about common sense and thinking about logically what makes sense for someone, it doesn't make much more sense. So it doesn't make sense, which is why I changed my practice. I stopped doing laparoscopic. Not to say that I won't do a laparoscopic myomectomy. I give the risk versus benefits, my thought process for it. If you still hell bent on having a laparoscopic myomectomy or robotic myomectomy, go right ahead. I will do it. I won't agree with it, but I'll do it. It's still your option, your choice. But I just want, like, you come back in 3-4 years and you got big fibroids, you want me like, Dr. Johnson, that's not happening. No, we ain't gonna do that, because we're gonna have a complete explanation about why I told you don't do it that way. Mm-hmm. And if you take the risk of them coming back like that, and then knowing that now you got these tiny holes, but holes nonetheless, and now you're gonna have a C-section anyway, it's just, for me, I stopped doing it for those reasons, and I strongly recommend doing open myomectomies again. Now, with open myomectomies, y'all know how I feel. Absolutely no vertical incisions, and as minimal as you can with the scar or with the incisions. The smaller the scar or the smaller incision, the quicker the recovery after it. So I'm all about you doing what they're going to do, a mini lap on you anyway, right? So they're going to, once they do this laparoscopically with the holes, they're going to do another incision this way anyway to remove the fibroids out. It doesn't make more sense to just use that incision, that small incision, and work with getting the fibroids out of that small incision, instead of struggling to do all of this work with the laparoscope and then making this incision to get the fibroids out. This doesn't make sense. Just make a slightly larger incision and do all your work within it. That would be my advice to you. Like, you may get, you just like everybody has an opinion, but again, there's levels to this. I don't do a whole bunch of stuff. I'm good at this, right? I'm not great at everything, but this, I will say I'm one of the best. And what I'm telling you is, this is how I think about it. And when you deal with something so delicate with your fertility, your uterus and all that, you want to go to somebody that knows exactly what the hell they're doing and can explain things to you from this level, right? Don't just do whatever you think they want. They should break things down so you understand it and let you make an informed decision about what you're doing. But that's my opinion to you.
All right. No, you good. How are you looking on time?
I'm good.
Okay.
I mean, we got time to make up, so I'm good.
All right. So we got somebody that's requesting to join.
Let them join. Hello.
Hello.
Hi. I just had a quick question.
Okay.
I had a surgery back in 2019, and it was a right opingo surgery. I think that's what it's called, where they actually removed my right ovary and a portion of my fallopian tube.
Yes, it's
Now,
opingo oophorectomy.
yes,
I'm not correct. I'm just saying that so people. I'm all about definition of terms, not just for you, but for everybody.
that's fine. So with that being the case, ever since then, I still have had like phantom pains when it's time for my ovulation or when it's time for regular monthly cycles. So I'm just trying to figure out, is it possible that something can be growing back?
So just because you have one ovary removed, you still have another ovary. You still ovulate. So
No,
if
I
you're
mean, I'm still feeling it on the right side. Like I know, like, okay, when I ovulate, I can tell which side I'm ovulating from because I feel the ovulation pain every month. Usually it's either on the left side or it's on the right side. So when it's
and when are you
ovulation
feeling
coming
that
through on the
pain?
right side, it's weird. I still feel that pain.
When are you feeling that pain exactly?
During my ovulation period, during a like actually on the 15th day of
Okay.
my cycle.
Right, which is called Hurts. So that's just a term for ovulatory pain, and the fact that you're feeling it on the right side doesn't necessarily it doesn't mean that that you're having a problem on the right side. You just may just be ovulating, and with the way the ovary sits, right? So your uterus sits down into your pelvis, and you can have it to where your ovary kind of like sits like in the middle and kind of gives you like a referred pain to that side. So if you're actually having pain from ovulation, it could be your left ovary still doing that, causing that pain on the right side. It's not a huge space down there. Like a normal size uterus is literally like that big, like the size of my hand, right? So if I have your ovary and fallopian tube coming off one side, so it kind of hangs. It can hang to the back, and if you're ovulating, you can have referred pain to that side. So that could be what's happening. But you also can have other things that are happening in your body. Did you get an ultrasound to make sure that there are no fibroids and other abnormal structures or anything else that are going on?
Fortunately, yes. I tend to get like a vaginal ultrasound almost every year.
Okay. Why do they do that?
Because I struggle with PCOS.
Gotcha. Okay. So yeah, if you took the ovary and if they took the ovary and the fallopian tube on that side, it wouldn't be from ovulatory pain from that side. If you're having ovulatory pain, it would be from the left ovary that's causing you to have that problem. And for that, if you're having ovulatory pain, the only true answer to that would be to stop ovulating. That would be birth control, or surgical removal, which you're not trying to do. But you'd have to give medications to prevent ovulation. I don't know if you're trying to get pregnant or what your status is with that, but that would be the only other answer to prevent ovulatory pain.
Okay.
Does that help? Does that help you?
It does help.
Okay.
Thank you so much.
All right, no problem.
Thank you for your bravery. All right. All right.
Still trying to figure it out. Put the top.
I got it.
Oh, you
teasing me.
Look up.
All right. So you said you're looking good on time?
Yeah, I'm good.
Okay. So since you were talking about laparoscopic, I did have a question that somebody submitted. So since we was kind of on that topic, and it says, is the only benefits of laparoscopic surgery for a patient the less invasive and less recovery time? And it's a two-part question, so I'm gonna let you answer that part first.
It's the only benefit. It's the only benefit. That's a great benefit. It's not just recovery time. Recovery time is one. Rate of infection is decreased. So you have decreased. So you have to think about it. Big incision, small incision, right? So open belly to the atmosphere, small incision open to the atmosphere. So the rate of infection is decreased with laparoscopic surgery. The bleeding is decreased, so because instead of cutting through all that tissue, you're making these smaller incisions, so you have less blood loss, less infection, increased rate of recovery, meaning your pain levels are less after surgery. You get out of the hospital quicker, which also decreases the risk of infection. The infections happen more the longer you're in the hospital. So if you can get in and out same day or the day after, you decrease the rate of infection. You decrease the need for narcotic pain medications. So having to take narcotics for several days or even weeks after surgery is decreased. So those are a lot of the benefits of laparoscopic surgery over laparotomy or open surgery. But again, everybody's not the candidate for laparoscopic surgery. Every surgery is not best for laparoscopic surgery, but in the nutshell, that's why laparoscopic surgery is more advantageous because of those reasons.
All right, and then their second half of the question was, what are the benefits of what are the benefits of having any type of laparoscopic surgery for the surgeon?
For the surgeon, well, it's for the surgeon personally is one, you get out of the hospital quicker, right? I don't have to deal with you as long. So if you don't have this pain, you don't have to, you're not in the hospital worried about, 2-3 days, worrying about being able to get up, being able to eat, and those types of things. So it's like, a lot of my laparoscopic surgery, you either leave same day or the day after. So it's less headache for the surgeon. And also follow up too. It's like when you come in, it's less pain, it's less, having to deal with issues after. So there is an advantage to surgeons, but that's not why we do it. It's for the patient. All of the benefit has nothing to do with my convenience or a surgeon's convenience. It's more so for what it's doing for the patient. It's decreasing, the pain and the recovery, helping you get back to work quicker, helping you being able to, get back to your normal daily routine quicker. So it's all the benefits for the patients that matter. As far as the surgeon is concerned, it's not as big a benefit for us. It's more so the patient.
All right. So if you're just joining, we are going to go a little bit longer tonight. Not too long because we don't want Instagram to act a fool and say we violating community guidelines, all types of stuff. But if you want to join, you can request to join at the bottom of the screen. And if you want to ask a question, drop it in the bubble that has the question mark in it, not the comment long bubble if you just want to talk in the chat, but please drop it in the comment bubble with the question mark. All right, so question in the chat. I have and I'm going to spell this, BICORNUATE.
Bicornuate uterus.
Okay, yep. With one side completely closed off. Can I opt to remove it?
I would say, why would you want to? If it's not causing you problems, just like with any other surgery, if it's not causing you pain problems, bleeding issues, and it's completely closed off, I would say no. If it's not an issue of infertility or anything else, then I would say no. You don't need to remove it. Anytime you just have surgery, surgery should be used when you need it. If you start doing surgeries when you don't need it, that's where complications and things can occur. So I would say don't do that. You could get in there, you take off that horn, you have extensive bleeding, and you end up losing the other one, your viable one. That's a complication that can happen. Like, why even put that risk? You do start to make risk when there is a reason to. When you have bleeding, when you have pain, when it's impacting your quality of life, then you can elect to do it. But no. So a bicornuate uterus is when there's a bifurcation or your uterus can have two horns on it, and that happens with development. And so she was born that way. And so in the process of development, things typically align in the midline. It can happen to where, you have two uterine horns that happen. Sometimes that uterine horn can be completely closed off, meaning that you don't menstruate from it, like nothing happens from there. But you can also have bicornuate uterus with significant bicornuate uterus, or not even bicornuate, it's called uterine didelphys, in which you actually have two separate uteruses that are coming and growing with two cervixes, or even one common cervix with two different uteri. It's multiple different things that can happen. But with that being said, if it's not causing a problem, leave it alone. That would be my advice to you.
And they said that the reason they were concerned is because they can't conceive and they're having heavy bleeding.
That would take a little bit more of a diagnosis. It might not necessarily be the infertility is caused from the bicornuate uterus, and removing it may not increase your risk of fertility. You have to really start to diagnose why you're infertile, or what the problem with pregnancy. Two things could be true at the same time. You can have a low semen count, and then you have a bicornuate uterus too. You got to diagnose what the true problem is. Removing that horn on the uterus and you have a low semen count is not going to make your rate of pregnancy any better. You have to diagnose it first. As far as the bleeding and things are concerned, you have to really analyze, is that causing the problem? And will removing that horn, will that improve your issues? So that's really like a specific diagnosis of what's happening with your body, and seeing what treatment options make the most sense for you. So that's a little bit more in depth. I would have to see exactly. That's something I would have to see in the office to see exactly what she has to be able to answer that better.
All right. So I got a couple of sexual health questions. Let's change subjects a little bit.
Yeah, I know it's one. A friend of mine was having this whole, is one of them about, because there was a lady in there that was some story about this woman talking about she had 2,000 sex partners, and does the vagina retract back or go back to it? Is that one of the questions?
That's one of them, but that's not.
Right.
So that's
not first.
next.
All right, we'll get to it.
That's coming up. All right. So the first one. First off, let me say thank you, DocP and Cola, for having this platform to share information with others. I'm 54 years old, and I had a hysterectomy with my left ovary removed, and then later my right ovary. My question is, what is the best way to combat vaginal dryness if I'm not on hormone replacement? And based on one of your previous conversations about how the more relaxed you are, the wetter you become, once you have no ovaries, is wetness even possible? I crave sex, but without lube, it's damn near impossible.
Got it. So, is it true that you can have that vaginal dryness is a product of estrogen production? Yes, it can be, but ovarian production of estrogen is not the only contributor of where vaginal lubrication comes from, if that makes sense. So whether you had your ovaries removed or not, at a certain point, every woman's ovaries are going to fail, right? I don't care who you are. You can be Wonder Woman, Bionic Woman, it doesn't matter. Your ovaries were created to stop working at some point. So whether they're surgically removed or physiologically non-functioning, the production of estrogen, the lack of production of estrogen is going to happen. For every woman, it doesn't have the same effect. So for some women that go through menopause, they may not have a symptom at all. They may have sex the same way that they had sex before. May have possibly an occasional hot flash, or maybe not have hot flashes at all. Those women are in the minority. Typically what happens is that women have symptoms but don't really have that they don't really have a true impact on their quality of life, meaning that they may have a little bit of vaginal dryness, they may have an occasional hot flash, but overall, their quality of life is not significantly impacted. Or if it's impacted, there may be certain things that they could do, like use vaginal lubricants, use some non-hormonal herbal remedies to help with some of their symptoms, or let's changing their layer of clothing if they're having hot flashes extensively. And then there's the other small group where they're having extensive symptoms from menopause that need actual medication to be treated, right? Sounds like she's like in that middle group. So with that being said, vaginal dryness is a consequence of menopause. It can happen. It doesn't happen to everybody, but it does happen. With that being said, you have a couple of options, right? It's not, when your ovaries are working, there's really no real reason why you should have vaginal dryness that's persistent. It's usually, again, don't take everything I say as definite. There are some instances that it's not, but usually it's from something that's happening in the relationship or something that's happening during sex where you can remedy the problem without doing medications or anything else. When the ovaries are not working and there's no estrogen being produced, or the ovaries have been removed and you're experiencing vaginal dryness from that, then we have options to choose. I heard her say that using lubricant, without lubricant, she would not be able to really have sex. Well, it's that optimal word. Using lubricant, she's okay, right? So basically, lubricant is just it's circumventing or taking the place of your body's natural ability to get wet from estrogen, right? And you're doing it yourself. You're still having pleasurable sex. You still, everything is still okay. It's just mentally, you're like, now I got to use lube. So what, right? You want to ask the question of, are you still having pleasurable sex when you use a lubricant? If the answer to that is yes, I would still use the lubricant. And just side note, from a lubrication standpoint, like the biggest thing is like it being messy or whatever. Silicone-based lubricants over water-based lubricants. Silicone-based lubricants, they're like slick oil type deal. They work much better. They're a lot less messy. So I would strongly recommend using a silicone-based lubricant as opposed to a water-based. For anybody that's like adverse to using lubrication because of the messiness or what have you, use a silicone-based. They work very well. But as far as what else you can do, if it's working, if it's not broke, don't fix it, right? If lubricants are helping you, have enjoyable sex, continue to use lubricants. Some women have it to where they're using lubrication and it still hurts. It still is not a pleasurable experience. And then for those women, there are medication. There is hormone replacement therapy that you can utilize to help significantly with that. I don't just free for all use hormone replacement therapy with every patient, because again, everything we do in medicine has a risk versus benefit, right? So if the risk is extremely high, but the benefit is not that great, then you don't do it. But if the risk is not as high and the benefit is much better, then you do it. So with hormone replacement therapy, there are risks associated with it, right? Just from a cardiovascular standpoint, blood clotting standpoint, like those, they're not very high risk, but they're a risk nonetheless. So if you can function without the need for hormone replacement therapy, then you don't necessarily need to do it. But if you're not having sex with your husband, y'all on the verge of divorce because y'all just you can't please your husband and life is miserable. You got all types of social issues that are happening from your inability to have sex. Then we start talking about hormone replacement therapy. So you just really got to kind of see and see what's happening with the particular patient and out and look at the risk versus benefit. But I will say, in a nutshell, to what she's talking about, if lubricants are working for you, and you just mentally just say, I don't want to use lubricants or what have you, think about it. You know, if it ain't broke, don't fix it. You know, be comfortable, okay, using lubricants. From a male standpoint, we don't give a damn. Honestly, I'm gonna give it to you from a man. We don't. You know, it doesn't hurt. I mean, now some men may be ignorant and they need some education, right? And understanding that it's not that you're not into sex, or that you're not, you know, she ain't getting wet for me like she used to. You know, just dumb shit. But it's just man stuff. Like, but it just takes some education. It's like she doesn't have the ability to produce this moisture. It doesn't mean that she's not into you. It's just physiologically not happening. They need to understand that, right? And that's a conversation with, you know, your provider or another man like myself that understands, to explain to them what's exactly happening. But if pulling that silicone-based lubricant, and the show still goes on like the show goes on, everybody should be happy. Keep rolling. Keep the good times going.
All right. Now let's get to the one that you already know about, because they definitely asked me a couple times. All right. So where is that in the list? Okay. I always get guys trying to tell me how our vagina functions. So I want to dispel the myth. So my question is, do women who have a body count, i.e. in the thousands, a recent post by some women on the Shade Room, does that make their vagina loose? I say no, but I could be wrong. However, I doubt it, especially because the average American size penis is 5.1 inches.
So that's Renita. So she posed this question. She was arguing with this man about the same issue, and this is where this came up from. Yeah. So think about this logically. All right. So I'm gonna answer this question. And the dude basically was like, he don't know what the fuck he's talking about. If you've been with 2,000 dudes, you gotta be wide as the ocean. Blah, 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 blah. Let me physiologically talk. Let's think about this. Let's break it down. Let's break it down like this. Yeah, she had 2,000 dudes or whatever. I don't give a damn if she had 5,000. Okay. Ask yourself this question. To answer this, let's look at it this way. If you have sex every day with 2,000 different dudes, or not 2,000 different dudes. If you have sex over, let's say, a 5-year period with 2,000 different men, and let's say, for instance, you had, in that same period, you had sex 2,000 times, and they're all different. Every different man, you had a 2,000 one-night stands for 5 years. You can't even do that. It's 365 days. All right, 10 years. Fine. Fuck it, my bad. 10 years, you had sex 2,000 men, and you had all one-night stands on this hand. Tell me what the difference is if you were with your husband for 10 years and you have sex 2,000 times with your same large husband man, and he has an above average size penis. What would the difference be as that relates to your vagina?
Exactly.
Don't make no sense, right? Think about it. You have to use logical, common sense when you think about things, right? And when people don't use your own understanding as far as like what society says, she a hoe, she can be whatever. That's fine. She said, Renee said, ain't say she had 1,000. So no. Yeah, I know you didn't say you have a 1,000 body count. Ma'am.
No, he meant it was your question.
I didn't say that. This was your question. All right, for everybody. Miss Renita Rhodes, it does not have a 1,000 male body count. Okay, this is hypothetical. This is whatever that lady's name that says she has a 2,000 man body count, and for everybody says that she has no walls and her vagina is stretched out and blah 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 blah. I pose the question to you. If you have a 10-year span where you have 2,000 different men that you've had sex with versus being a committed relationship with your husband, and you all have had sex every day or had 2,000 sexual experiences or encounters over that 10-year period of time, will we say this woman has no walls or anything else? No, we say she okay. It's the societal or societal thought process that because she's promiscuous, that now her vagina is going to take the effects of this pounding by 2,000 different men. That it just doesn't make sense. The vagina is one of the most resilient organs, tissues, and no, there is, right? You can have a 8-pound baby come through this same hole and it goes right back, right? You can have a woman that has had 4 or 5 children and have tightness of the vagina. There's not a man that can recreate the size of a normal child with his penis. Cannot. I don't give a damn how big, how long, how small. It doesn't matter. This vagina accommodates an 8-pound mass, stretching it and going through. It comes back together. Sometimes 9 pounds, sometimes 10 pounds, sometimes 11 pounds. And for the majority of those women, you would never know it. Like, no, I'll take that back. Is there some laxity in the vagina that can happen with it? Yes. That has more to do with genetics, and the amount of children a woman has had, because I've had women that have had 5, 6, 7 babies and still have very tightly formed vaginas. And I've had women with 5, 6, 7, 8 babies that have loose vaginas because of the stretching over time of these large masses of babies that have happened, and because their collagen makeup or structure to their vagina is different, right? Which is the same reason why I can have a woman that have 5 babies and have horrible prolapse of her vaginal tissues, and another patient that has 5 babies that has an intact vagina, tight, and everything else. It has a lot to do with genetics and your collagen makeup. Just like when you cut your skin, like 2 people can have the same cut of their skin. I think my ear pod went out. 2 people can have horribly, the other one heals regularly, right? Everybody's skin is made up of different components, right? And that has a lot to do with genetics. Same way with vaginal tissue and laxity as well too. But as far as a penis is concerned, if she could have 2,000, you have no idea the size of the penises of these dudes, right? Maybe if she was into having sex with horses, or penile enhancement dudes, with arm shafts, then maybe, okay? But if she's having sex 2,000 times with a normal or a slightly above normal sized man, it is not going to stretch her vagina out anywhere near what a baby would do it. So that woman has had 2,000 sexual encounters. It really also, it depends on her age. It depends on, has she had children? Has she, has she been in a occupation in which she's lifted chronically? Like, is she a smoker in which she has chronic coughing? Those things play more into the laxity of the vagina as opposed to how many sexual partners we have. I never asked that question. That's not a question where I talk about with prolapse. Okay, ma'am. So you're having your vagina come, it's starting to protrude down or what have you. I'll ask them, do you smoke? Does anybody in your family have issues with prolapse? What's your profession? Like, what do you do? Are you a mail carrier? You're a CNA, or you sit at a desk job? I'm asking these questions. I'm not asking how many dudes you can screw. I'm never asking that because I don't give a damn, because it has absolutely nothing to do with the laxity of your vagina or if prolapse is happening or if you're going to have loose walls and everything else. This is from personal experience. I've been with women that have had multiple children and women that have not. And the laxity in the vagina is is different. Like, the woman with multiple children has more structure or more firmness of their tissues as for someone that didn't. So it has much more to do with all of those other factors that I'm talking about, as opposed to, did she have sex with you know, however many dudes, and her walls are going to be broken down. That's just our ignorant way of thinking, that we just don't understand physiology. But that's why I'm on here educating us about us. So that's that. Hope that answers the question for you, Miss Rhodes. And that guy that said, I don't know what the hell I'm talking about, and my doctor told me, blah, blah, blah.
Yeah, he said
Whatever,
your accolades was trash. You didn't even
man.
know.
Trash these. You know what I mean? Like, stop it.
All right. Well, I don't want to go too long because, like I said, I don't want to get cut off. But
yeah, what is
we
it?
definitely
It's like a 2 hour
gonna do
cutoff.
this.
What time we start?
I think we started at
7:40 or something like that.
5, something like that.
Yeah, we got a little bit of time. I think it cut off at like 2 hours is the cutoff.
2 hours
So
is the cutoff. Okay.
yeah, I believe so.
Okay.
I believe so. So we won't go past, let's say, 9:30.
Okay.
And then
we'll do 15 more minutes. All right.
Yeah, we'll do
So
15
if you
minutes.
want to join, we doing 15 more minutes. Please hit the request down below to join. I'm gonna try to get to some of the ones that's submitted because, like I said, we playing catch up. That was submitted months before the last month.
So we'll do. I mean, we could do another one like less than a month to catch up. So we could do one in another couple weeks. That's fine if you want to do that.
Yes, thanks for recording it and sending it to him. Matter of fact, when I post this one, I'm gonna say, "Do body count matter?" All right.
And people ain't gonna be like, he said that. Like, I when I give these explanations, I'm very clear. I know what I'm saying. I choose my words very carefully, right? So realize I don't trip up with my stuff. Like I know exactly what I'm saying. So I'm very, very specific about what I'm saying. So you can share it. I will stand behind everything that I'm saying. Anybody can come and try to holler at me about it. Like I'm good. But go ahead.
Same dude talking trash is the first one in her DMs. Trust and believe.
Correct. You be like,
right.
Put a blindfold test. Like, who got the 2000 and who got the one? You wouldn't know. He wouldn't know. Good.
No, you good. All right. Sometimes I pee a little when I sneeze. Should I be concerned?
So what she's talking about, so peeing a little when you sneeze, that's called stress urinary incontinence, right? What stress, so there's two different type of incontinences. One is called urge, which means that you have the urge to go to the bathroom and you can't make it to the bathroom. You're losing. Incontinence means losing urine, losing feces, losing a bodily fluid that you don't intend to lose when you don't want to lose it, right? You can make it to the toilet, it's not incontinence. If it happens when you're trying to get there, that's called incontinence. So urge incontinence is one. That's when you have the urge to go, I gotta pee, and by the time I get up and try to get to the toilet, it's already in your pants. That's urge. Stress incontinence is when you laugh, cough, sneeze, or put pressure down on your pelvic floor, and when that pressure happens, you lose urine. And the big differences between those two is that for urge incontinence, the treatment is for medicine. It's not a surgical treatment. It's a medicine, just depending on how bad it is, right? Because sometimes you may have, we look at it episodes. If you have an incontinent episode, maybe like once a week or, once a month or whatever, that's really not that bad. You don't have, there's things that you could do behavior-wise to counteract that without doing medications or anything, right? That's urge. Stress incontinence is different. There's not a medication for stress incontinence because it's a structural issue. So your bladder sits up above your vagina, right? And your urethra is the short tube that goes out and releases the urine from your bladder. Well, that urethra, which is short in women, is held up by structural tissue to hold up just like this, right? And so when you pee, right, there's a sphincter on the urethra that you release, and urine comes out. Well, with stress incontinence, the structure that keeps that urethra up is down. So there's a kink in the urethra. So instead of the urethra being like this, it's a kink, right? So the structure is not. So remember I talked about the pelvic floor and the pelvic floor having all of these structures and keeping everything up. Well, if that structure up under the urethra is kinked, or is weak, it can cause a kinking of the urethra, right? When that happens, that's the part of stress incontinence that's issue, because when you laugh, cough, sneeze, so when you have stress incontinence, the urethra is kinked, meaning that it's laxed. It's because it's not supported all the way up, which now means that when you laugh, cough, sneeze, you do that. And so now it straightens it up and you lose urine that comes out of it that way, right? And so for that, you have to fix the structure to prop the urethra back up so that there's no kinking in it anymore. What causes the kink, it's not a real kink. We call it a kink. It's not a kink. But what's causing it is that your urethra isn't kinked. It's just that it's supported by fibrous tissue that's up underneath it. With time, that fibrous tissue can get laxed and lose the support, and then that straight urethra can now be kinked, meaning that it can it's not kinked in the fact that it's structurally changed, but it doesn't have that structural support under it. So now that it starts to sag, right, and it's not straight anymore, and that what we call kinking, but laxity underneath that tissue causes the urethra to not be straight anymore. So every time you laugh, cough, sneeze, it'll straighten up and you'll lose urine. So it depends on, all that being said, it really just depends on how bad the stress urinary incontinence is. Again, if it happens once every week or month and it's not that bad, you don't need to do anything about it. You could just change your bladder behavior, meaning don't keep a full bladder. When you drinking a lot of water, go to the bathroom on your own, so that when you laugh, cough, sneeze, there's no real urine in there. You don't have that problem. If it's happening very infrequently, if it's happening very frequent, where you're soiling your pants multiple times a day, or every time you at an event you laugh, cough, sneeze, you losing urine, then you got to start talking about treatment options, which are surgical typically, or pessary, to treat the stress incontinence. Right? It just really is, again, risk versus benefit, how bad things are happening. Do you need surgery? Do you need treatment? Or if it's something you could live with. If you could live with it and it causes you a lot of problems, it's not going to kill you, leave it alone. If you are playing with your kids, playing with your grandkids, you're trying to go to events, you got white dresses on and you're peeing on yourself and you got to wear undergarments and diapers and things, what have you, and it's a big stress, causing a social stressor in your life, and now we need to talk about surgical options to treat it.
Excellent. All right. DocP or Cola, can you describe being put to sleep? Is it scary? I want to have an elective surgery this year, but that is my biggest fear. Oh, you want me to answer that one? All right.
You just did it.
Yeah, it was a year ago.
Right.
I don't really remember being put to sleep, but I will say, and I wish I would have watched this before I had surgery. You have a YouTube where you talk to your other co-author of your book about what being put to sleep is and what it's not.
He talks about it very extensively.
What they do.
Yeah.
Anybody who follows Dr. P, you could go search Dr. P on YouTube. If you watch that, I think personally it will ease your concerns, because the way he break it down is like, okay, they put on the medicine, then when they want to wake you up, they just turn it off. It's not really a lot. I think we think it's way more to it than it really is. So I would say watch that, but unfortunately,
yeah, the podcast is still there. I got to start my podcast back up, golly. But Doc for the Streets podcast, I got 5 episodes in there. I'm going to restart my podcast. I'm trying to rebrand to figure out exactly what I'm going to do. I think my daughter is pushing me to do a podcast with her. And I think that's where I'm going to do it, because I need something that I can really just like do consistently. So I'm going to restart my podcast. But for those 5 episodes, they were really, really good. But the one she's talking about, you could look at it on Spotify, Apple Music. Doc for the Streets podcast is the one with Dr. Maxim Madir. He's an anesthesiologist, and he explained, that's my best friend, that talks about extensively how just the anesthesia process, the medications, everything that goes into it. I guess I could speak on it. I had a colonoscopy, was that a year ago? I can't even remember. It was like last year. And it's not bad. I mean, like, going to sleep is really like the best sleep in the world, so I wouldn't necessarily be scared. I would definitely have a conversation with your anesthesiologist. Conversation and information and discussion always helps when you have to go undergo like a procedure. But with that being said, again, it's risk versus benefit. If you got to have surgery, you can't stay awake with surgery. It's something that has to happen. That's why you talk about elective surgeries and elective risk. So you don't want to just electively just do surgeries if you don't have to have surgery, because there's a risk of everything. There's a risk of having anesthesia. There's a risk of the surgery. There's a risk of everything. So if you're going through those risks, make sure that the risk is worth it. And if you have to have surgery, yes, it is. That means that your benefits of having the surgery outweigh the risk. But, as far as the fear is concerned, education helps alleviate fear. So talk to your anesthesiologist, talk to them about all your fears and all your anxiety. That if they are good, like they should be, they should talk to you very freely about it to help alleviate some of those fears and anxieties.
And I probably would have paid attention more if that was one of my fears. But my fear was just surgery in general. It really didn't have to do with being asleep. I just didn't want to have surgery, period, point blank. So I don't really remember it. So I would say from a patient perspective, it's obviously not that bad because I don't remember much about it. But I do remember watching that video after my surgery because I was bored and I had a lot of free time. And I remember watching the episode and I was like, wow, I wish I would have watched this first, So, yeah. All right, well, we're going to get ready to close, but before we close, I do want to give one testimony that I was sent over the period that we've been absent, and I just want to share this because this is one of the reasons why me and DocP are committed to what we're doing in the first place. All right, so the person wrote in and said, hi, Cola. I wanted to provide an update. I submitted a question a few months ago regarding light uterine bleeding that I noticed after using my vibrator for external stimulation. I was so embarrassed and considered throwing it away since that was the only time I saw the bleeding. But you and Dr. P made it easier for me to follow up with my doctor to address the issue. Long story short, I had a uterine polyp that was recently removed, along with the endometrial biopsy and a transvaginal ultrasound. I'm patiently waiting for the results, but if it wasn't for this platform, I might have waited, and who knows what the outcome could have been. So thank you both for your dedication and commitment to providing this education to us. So I thought that was an awesome share. And
that's super dope.
Kudos to that lady for taking action because, I sat on fibroids for a long time.
She said, tell people to install the two-factor authentication. I encourage that, but if a hacker gets past that, like my hacker was able to, and it was just me being not thinking, because he not FaceTime, and this is totally off the damn subject, but I just read what she was talking about.
No, it's okay.
He WhatsApp video me. And for everybody, like, he ain't got to be Nigerian. Yes, he's Nigerian. I talked to this little mofro. Like, I seen his face and was ready to kill him, but I couldn't get to him. So, but I was so mad. He was like, you want your page back? It wasn't this time, but he called me another time. You want your page back? Put this passcode in here. So I thought that, like, I could get into my page real quick and outsmart him. And he was like, put the passcode in that he told me, because he already had complete control over it. And when he did that and I tried to get into it, I got into it, but he snatched it from me. But then he was able to get a deeper stronghold on my account when I did that, because now he had like he could bypass the two-step authentication through my phone. So like every time they send me a message to my phone, it was going to him. Anytime they send an email to me, it was going to him. So he was able to divert everything to go back to him. So he had me like by the, and it was nothing that I could do about it. Like, so yeah, I agree. Two-step authentication. My advice, don't answer nothing. Like for real. Like if you now I'm apprehensive about answering anything. Don't ask, like, yeah, granted, if it's medical questions, yes, I'm gonna answer that. Anything else? Man, don't ask me. Like, call me. That means you need to know me personally, so you can call my phone, hit my line. But I'm no DMs, all that stuff. Like, I used to just be kind of free with like answering questions and do all that stuff. Now I'm looking everybody's side eye.
Yeah,
that's how he got me. He got me from like my mentee, like, and it just sucks.
Yeah.
So you thought I was racking up on Forex. Yeah. Listen, if I tell you, listen, if I can give, well, think about this, right? And this is logical thing. This is logical shit, right? If I can put $200 or $300 and I'm gonna get $4,000 back, why the fuck am I gonna tell you about it? I'm gonna find every $400 that I can and run that back every time, all day long. I'm gonna do $400. I'm gonna get $4,000 back. $400. I'm gonna get $4,000 back. I'm gonna use my mama's name, a grandma's name, a sister's name, a cousin's name, your name, his name, everybody's name. I'm not gonna ask you to put $400 in there to get you $4,000. I'm gonna get it for myself. So just think about it logically. It just doesn't make much sense to do that. But I digress.
Yeah, but no, two-factor authentication is important if you do it prior to you getting hacked, because see what happens to you. See, now I know a little bit.
I had it though, but that's the thing. I had it. He got me.
He still got.
Once you give him information,
Yep.
he got a link from my email. Once you give him information or you got information, I didn't give him no money and none of what have you. But it was somebody that I trusted, that I was mentoring, that I actually had spoke to before, had a thread with before. It was like, Instagram sent you a message. I was trying to get my information back. Can you please help me? And I hit the link. Once I hit that damn link and showed him the link, got my ass real quick. Boom, 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 boom.
That's how they get you.
Kick me out and everything. Tore my ass up.
Yeah.
Never again.
So when people DM you, I don't care if they telling you vote for them in a contest. Man, if they ask for any link, you should be able to just vote and then go about your way.
Correct.
But if they say,
I
need the link, I need the passcode, I need the connection, I need the register, don't trust none of it. I was definitely telling people to report that Forex page every single day, not just once, every single day. Because if I know one thing about production, even when it don't seem like it's there, if they see the flag coming, they looking at that. So that's why I told people, no, don't report it one time. Report.
Just keep doing it
every day.
Yeah,
and that's what
it was hell getting back on. You can't, like, they tell you could do this video thing, but I still never was able to do the video thing. The way I got them back, they finally sent me a code that I was able to use. They sent that code. I was able to get in. And when I got in, I had multiple devices opened up. So as soon as I got in, boom, I went straight to the setting. I snatched it back. I had to do it right away because they be on it. Like, if you get in and you finally get back in, they're going to snatch it back from you. So when you get in, you got to have everything open, get it back, change it, lock their ass out. And that's the only way you can get it back. Because this lady that just DM'd me trying to get her stuff, and like, somebody told me, blah, 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 blah. You can help me. I was like, this is all I got, mama. I ain't sending you shit, but I'll tell you what happened to me because I feel bad for you. Because she was. I looked at her page. It was legit. Like, they hacked the hell out of her. She had like 10,000 something followers or whatever. And now she had to get a whole nother page. She can't get it back. So I told her, but man, it is horrible. It's horrible. Like,
well,
watching somebody just destroy you and you can't do nothing about it. Well, go ahead.
No, we definitely glad to have you back.
Thank you. Good to be back. I thought I was done though. For real, I was giving up. I was like, I ain't starting on another page. I'm just going. I'm
done.
And
I was telling you, stop thinking like that. Remember we talked.
You did.
You wasn't gonna do that.
Did. I was done. I was like, man, F this. I quit.
Sometimes you have a setback for a bigger comeback.
True.
See?
Absolutely true.
So I'm
gonna do bigger things.
I was gonna be on your behind if you was trying to be like that.
Yeah, you did. You was on.
Yeah, but I'm glad you got it back. All right. Well, I don't know, but I'll reach out to you for the next one. We may do before a month. I just gotta look at my calendar too. But yeah, but definitely thank you. Thanks everybody who joined. Thank you who joined in person. Thank you all who dropped questions. Really quick before I close, I'm a screenshot because there were a couple I didn't get to.
Yeah, and make sure you because I'll just when I can, but you're gonna have to put it on your page. I'll direct people to your page when you post it because I can't post it. I'm in jail still. So
yeah, and I'm gonna post it to YouTube too, so it'll be on there.
Okay.
I'm actually gonna end up redoing the YouTubes to give us a little bit more sentences. Okay. So I think I got everything screenshotted. Wait, hold on. One more.
Thank you.
Okay. All right. So I got all the screenshots. Again, much appreciated. Thank you for your time. I'm FREE, fibroid free. I ain't got
Congratulations, 1 year anniversary.
Bleep. No, I've been singing that all month. I'm telling you, I'm gonna get put out of my house. At the red light, turning up. Okay, no.
Hey, you gotta put a video out. I'm gonna share it. Go ahead.
Yeah, I know. We gotta do like on the Tesla. See, perfect.
Got it. That's the
Not
last thing the
Alexis,
Tesla we're gonna
the
do it next time. Man, that shit made me so mad, man. I was like, God damn, he got me out here bad.
Yeah, but no, thanks again, and we'll definitely do this again.
All right, y'all.
All right.
Till next time. Talk to y'all later. All right, save it because they gotta go and post it right away because it'll mess up on you.
Yeah, no, I'm gonna post it right away. Like I said, I'm gonna post it. Do body count matter?
All right, y'all.
All right, y'all. Have a good one. Bye bye.
All right.